Good afternoon, ladies and gentlemen. Welcome to today's webinar. My name is Wan Thung from the National Cancer Society of Malaysia, and I'm delighted to be the moderator for today's session. As you may know, World No Tobacco Day is coming up on May 31st, 2023. So to celebrate, we from the National Cancer Society of Malaysia have organized a series of webinars titled Harms of Harm Reduction in Tobacco Control, running from April to May 2023. So this series of webinars aim to raise awareness about the false narrative of harm reduction strategies in tobacco control and their impact on public health. So over the next 8 sessions, we'll be exploring various aspects of harm reduction in tobacco control, understanding the issues with vaping and health, which is kind of a hot topic right now, communication strategies in dispelling those common myths and misinformation for our tobacco control advocates. So we have invited representatives who are strong advocates in the field of tobacco control to share their expertise and insights in support of this series of talks. So today's session is the first in the series, and we will be exploring the topic of the false narrative of harm reduction. So today we have two speakers with us today. Our speakers for today are Dr. Murallitharan Munisamy, the Managing Director of National Cancer Society of Malaysia. And we are also honored to have Dr. Noraryana Hassan, who is a public health specialist and the Senior Principal Assistant Director of the FCTC and Tobacco Control Unit, Disease Control Divisions, and CD Ministry of Health Malaysia, for joining today's session. So thank you, Dr. Murali, and thank you, Dr. Ariana. So as the first speakers for today's session, Dr. Murali will be discussing the principle of harm reduction, explaining what it is and its application in public health. After that, Dr. Ariana will speak to us about harm reduction and the false narrative by the tobacco industry. So if let's say you have any question, please feel free to drop your questions at the Doctortip platform. And now, Dr. Murali, over the sessions to you to start the first presentation.
Okay, so good afternoon. Thank you so much, Ms. Wan Thung, and always a pleasure to be able to speak to our colleagues in the profession. And of course, we're especially delighted to be able to have Dr. Ariana, our Director of the FCTC Division of the Ministry of Health, and who now is just taken on a new role to oversee NCD for the Ministry of Health Malaysia as well. As we come up to this year's World No Tobacco Day, which is on the 31st of May, and I think Ms. Wan Thung alluded to it quite significantly when she spoke to the problem of I would say, the misuse of the term harm reduction. Both Dr. Ariana and myself are public health physicians by training, and we come from a long and kind of very concrete idea of the term of how harm reduction is used in public health. And we'll make an argument to you today and share some data on how actually the tobacco industry has actually worked very hard to kind of misappropriate this term, use it in shaping a very different narrative, which is actually causing to a lot of harm in tobacco. And this series is actually designed to actually address these harms in terms of the usage of the term harm reduction in tobacco control. And so, of course, for many of our colleagues who are not in public health, I think there's always this idea of what is harm reduction. And this first episode, will be speaking to you about two things. One is what is actually the principle of harm reduction, and I'll spend a bit of time on that. And after that, Dr. Ariana will come on to give a little bit of a glimpse of how harm reduction, this term, has actually been kind of used in a very, misappropriated manner in terms of tobacco control today by tobacco industry and their kind of narratives. So this is where this session is coming to you about. So I'm going to start talking to you about harm reduction and actually what is this term entirely about. So actually this entire term of harm reduction as we know it is about strategies which are targeted towards individuals or groups aimed at reducing the harm or the harms that they are being exposed to due to certain behaviors. And traditionally, harm reduction, you've used this concept to apply, you've applied this concept to substance abuse, but also now to a lot of high-risk behavior. And as we know, a lot of public health issues are very governed by individuals or groups actually indulging in high-risk behavior. This could be substance abuse, such as drugs. It could be abuse of alcohol, and of course, lifestyle behavior, including unsafe sex and a lot of other kind of high-risk behaviors. Now, harm reduction works on the premise that while people should entirely stop from abusing a substance, right? For example, if you're a drug user, the idea is that you should stop using drugs entirely. But harm reduction comes at this approach in a very realistic manner, perhaps saying that this is not going to be possible for all the people all the time. And so if you cannot help and get them to stop entirely using this substance, I should be able to reduce the usage of this substance in some manner. And that is basically the kind of governing premise of harm reduction. And so if you could not get an individual to quit using a substance, then the kind of premise is then we should provide them with some alternative that will enable them to do less harm to themselves. That is really the idea of harm reduction and where this is coming from. Now, one of the big areas in which harm reduction was actually originally introduced was in public health within the context of needle exchange programs for injection drug users, IDUs. And originally, and this is in the early 80s and the 90s, you began to see there was a huge public health problem, communicable disease problem, in which is actually HIV. I'm sorry, there's a typo there. It's HIV. And subsequently, in later years, we began to see like an increase of hepatitis C as well. And a lot of this was actually seen within the IDU community because they were using or sharing contaminated needles. So one infected person, a person who was infected with HIV, would subsequently who had used the potentially contaminated equipment, needles, syringes, etc., would actually exchange that with other people, and they would then cause a transmission of disease from this person A to person B and so on and so forth, detrimentally impacting the community of IDUs. So under this harm reduction principle, the idea was, sure, it's to support them to stop using drugs at some point in time, but in the immediate urgency was to make sure that we could protect them from actually getting or the spread of HIV within these groups of people. And the idea was then to introduce something to enable them to not have to share this contaminated injection equipment. And as a result of that, these needle exchange programs were born. So needle exchange programs or syringe exchange programs, depending on different contexts, different places use different programs. So basically they gave clean equipment, sterilized one, so that contaminated equipment was not shared between the IDUs. And the idea was so that this could decrease the spread of bloodborne diseases, HIV and hepatitis C. And evidence has shown us clearly in many countries, including our own, there's been a lot of work done by University of Malaya in this regard. Prof. Adiba and her team have done quite a bit of work around this area. And evidence has shown that with needle exchange program, like the seroprevalence of HIV really can be decreased within these individuals and these groups of people. So it's really been a very powerful public health tool that we have used within the public health context. Another similar kind of program that we have been using in Malaysia as well, together with the Ministry of Health for quite a significant period of time, has been methadone replacement therapy similarly onto groups of people who are IDUs, injection use individuals and communities. So what the idea is that IDUs are then able to use methadone. Methadone is a drug which synthetically produced, which has very similar chemical properties to heroin or morphine, but without the kind of euphoric component. And you substitute methadone to these individuals rather than for them to actually get on to using injection equipment to deliver drugs such as heroin or morphine to themselves. So methadone is given orally, it's given within a kind of a supervised setting. So the idea is that, again, IDUs would not need to use injection equipment, which can then be contaminated and decrease the spread of bloodborne diseases like HIV and hepatitis C. Again, this has been a really powerful tool to aid IDUs in preventing them from spreading these bloodborne diseases. And both within our country and in other countries, the context has been well documented. So I'm going to kind of go a little bit back in time and talk to you about actually how do people come up with this entire idea of harm reduction. So as I was telling you, increasingly in the perhaps early onset of the 20th century, our largest problem in public health was really nutrition, communicable disease, and ironically with COVID-19, it seems to have returned us to the era of public health dealing with communicable disease. But over time, there's been this large shift in terms of behavioral problems pertaining to which are driving public health issues. One of that has actually been substance abuse, and of course, the second of the multiple different mechanisms has been in the use of other risky behaviors. Now, there have been various approaches to tackle these issues, which are really driven by the idea of behavioral modification. And largely prior to this whole concept of harm reduction, we tackled these kind of behavioral this propensity of individuals to engage on risky behaviors, as well as such as substance abuse, via three different mechanisms. One, we went at it by trying to discourage the behavior completely. And if I could use another public health term to kind of describe this, it would be kind of primary prevention, where you actually stopped people from ever using these substances or indulging in these risky behaviors ever in their lives. So an example of this is education programs at the school level to school-going children to prevent them from ever starting to use alcohol. So this was an approach. We continue to do this, of course. It's health promotion, health education. But what we also did do was we encouraged reduction of the behavior. So, for example, we ran educational programs to limit the number of drinks that are consumed by a user, or you had actually policies in some bars, not here in other countries. Perhaps we don't, I don't particularly see that here, but in other countries, there are policies in bars that actually prevent alcohol drinkers from purchasing more than an established limit. Another kind of common policy is to prevent sales after a certain period of time. Even our neighboring country, you have seen this in Thailand, for example. There's limits on what time and after what time you can't buy alcohol. So these are kind of policies or educational programs that you can put in to limit the number to kind of people who are already engaging in the behavior is to encourage reduction of that behavior. And of course, the third approach has been to reduce the harmful consequences of this behavior when it occurs. And for example, again, if you notice, I'm using alcohol as the example here largely because you'll see a lot of other examples. Like I said, harm reduction largely talks about drug or substance use, and we'll use those examples there. And of course, Dr. Ariana will be speaking to us from the tobacco control kind of landscape and giving us examples from there. So in terms of reducing the harmful consequences of the behavior when it occurs, in terms of drinking, I think one of the big problems that is often brought up in the context of alcohol abuse is that of drunk driving. And in terms of reducing the harmful consequences of the behavior, then the context is to actually introduce policy controls, basically laws that prohibit drunk driving, huge fines, and now and even in Malaysia, I think recently we increased the severity of punishment that we've put into place for people who are drunk driving to prevent users indulging in this risky behavior. So the idea of these three approaches have been successful to some amount of varying degree. However, there's still a lot of challenges in terms of widespread success on a large scale and in a sustainable manner. And the reason for it really is because in the reality, and this is really the reality, is that while we can stop people, we find that health promotion is very effective to prevent people from starting on the path to a risky behavior. For example, if you are a never alcohol user, okay, then it is easy for me to put in health promotion measures that actually prevent you or motivate you or disincentivize you from ever kind of going into behavior that in which you will use alcohol. And there are many approaches for that. Successful works. However, if you're already an individual who's using alcohol, okay, it's going to be very difficult for you to actually eliminate that behavior. And this is what I think our colleagues across psychiatry, public health, psychology are finding in terms of adults. That people who are already indulgent in risky behavior, they are interested in reducing, but they are not interested in eliminating their risky behavior. So, and this is a very, very, problematic kind of situation now they're finding out, because our entire, and we'll speak to that in a bit, as in our entire approach has been to get people to eliminate their risky behavior. Now, what has kind of happened over time is public health professionals are actually increasingly, more pragmatically, I feel, adopting a more realistic and practical approach. So traditionally, you know, what we do is traditional law enforcement approaches. We always believe in kind of putting on a law, such as to arrest and jail drug users, for example, or treatment approaches such as like quit entirely. This idea of putting you into rehabilitation centers and like pusat serenti and, you know, push you to quit entirely. But these have not been terribly successful, not only in Malaysia, but also across the world. So it's actually no real reduction in terms of demand or use of drugs, as well as the health outcomes related to drugs have actually happened due to these approaches. So harm reduction then is seen as this kind of more pragmatic, real world approach to tackling these kind of big public health issues. Now, there's a couple of three big ideas behind harm reduction, kind of the big, I would say the central tenets of harm reduction. One is the idea that harm reduction is a public health alternative to the moral and disease model that's currently always being discussed in terms of substance use, or actually even indulgence in high risk behavior. Harm reduction, okay, recognizes that abstinence is the best outcome. but it's able to understand and accept that there's a lot of alternatives that will result in reduced harm, and that this getting to abstinence is actually a journey, and we need to actually hold the arm of our client, patient, whoever they may be, across this entire continuum, step by step. And most importantly, harm reduction also promotes a low threshold access approach. What do we mean by this? First, okay, when you talk about this substance addiction or use of high-risk behavior, there are two models that are always discussed. The first is this idea of the moral model. That means, what do I mean by the moral model? The moral model presupposes, or puts out the supposition that this substance that you're abusing, be it drugs, or alcohol, or high-risk behavior, is actually something that is very morally and criminally wrong. Okay, and so you should undergo some sort of punishment for it, and by using this, you have actually broken the law. So it frames it in a very legal perspective, and of course from a moral perspective, and it approaches this under the idea that you should be punished for having utilized this substance. So that's the moral model. In the disease model of substance addiction, we actually look at substance addiction from another aspect, which is that you are actually, this substance use is actually an addiction, and that you are a patient and you need to be treated to be cured of this addiction. So these are the kind of two models that are generally used when we talk about substance use, substance abuse, and the use of high-risk behavior. Now, harm reduction draws on both these models, but is not dependent on any of them. So harm reduction takes a very non-judgmental approach to actually, look at this individual and to understand that while this person has a problem, okay, getting him or her to actually stop the problem entirely may not be a practical solution. Rather, the idea of harm reduction is, how can I get this person to not do more harm onto themselves while they're already in or utilizing this kind of product or substance? So, or indulging in this high-risk behavior. And that actually builds on the second kind of central tenet of harm reduction, which is the premise that rather than a dichotomous outcome where you either use or you stop using, which is like kind of where this moral model or the disease model comes from, is so if you use, you're not guilty. If you don't use, you're not guilty. If you use, you are guilty and you need to go to jail. Or this idea that if you use, you're an addict, and if you don't use, you're not an addict. So this very dichotomous outcomes that are present within these current two models, harm reduction actually takes a middle path. It says that, hey, look, actually, there's an entire continuum. Some people may use a little bit. Some people may use more. Some people may be completely dependent, like become absolutely addicted to it. But there is a wide range of users. And more importantly, while we are aiming to move everyone to abstinence as the best outcome, meaning finally we want to get everybody to quit using these substances, okay, we need to also be cognizant that people will continue using. Users may use at different levels, and the idea is for us to constantly put in interventions that can help them to, one, maybe not get worse, which is a good thing, and second, not get kind of additional harm from utilizing these substances. So that's really the idea. And how do I make this happen? So harm reduction promotes this idea of a low threshold access. What do I mean? Harm reduction very often, and you see this in addiction, the drug users, okay, are always stigmatized within society. And it's not easy for them to go to seek services or seek both, either whether it's social services or health services. They are often denied, stigmatized, and often ostracized, not given access to, even if they did want treatment, they're always kind of looked at and approached in this manner. So harm reduction actually calls for this idea of a non-judgmental approach through avenues such as community settings, and as well as the use of services which are accessible to individuals who are indulging in high-risk behavior or using substances, in order to give them access. And that is the idea of harm reduction, so that they will uptake of these harm reduction programs, and even if they can't quit outright, they are able to reduce the harm that they're doing to themselves as well as to others, possibly. And so that is the idea. Now, do we use a lot of harm reduction? Increasingly, and among my colleagues who are primary care practitioners as well as clinicians, we're finding that in a world where our patients are a lot more empowered in terms of decision making, the real, the real sad fact, or the reality is, I say sad as a clinician, because I mean, we understand harm reduction, but as clinicians, we are always kind of thinking, and we're even trained in that manner to kind of move our patients towards zero harm or abstinence, as that may be. So we actually are kind of looking at how we incorporate more and more these kind of ideas or the principles of harm reduction within our patients. For example, very simple, I have, I manage patients with cancer, and even some of them, it's even though with lung cancer, they will not quit smoking. Or even I see individuals with other kind of cancer, even liver cancer, who will not stop drinking or using alcohol. So the idea to them is either if I could use the term absolutist, then I would tell them, oh, there's no point to come for a treatment anymore. You should just, go home and die, and I'm not going to treat you. But in reality, that's not what we do. As physicians, we actually don't prejudge our patients. We continuously work towards a slightly better outcome, step by step. And that's how we are actually incorporating various principles of harm reduction within our kind of clinical practice in day-to-day. So some kind of ideas of where we are in terms of harm reduction, and incorporating those principles onto our life is, I'm a little cognizant of time, and I want to give a bit more time to Dr. Ariana, so I'm just running through these concepts to you. Is one about humanism. So and I'm sure many of my colleagues, if we were in a face-to-face setting, would actually kind of be able to immediately correlate to me on how these are things that you're actually already doing in your daily practice, while you're applying this very important principles, which are the core principles of harm reduction. One is the idea of humanism, the idea that as healthcare professionals, we will treat our patients with kindness, respect, dignity, and recognize them as individuals. So when we recognize them as individuals, we also understand that some people have reasons for harmful behaviors. They're just going to do that. And again, we also kind of understand that these behaviors are not necessarily something that's within their control. Increasingly, we're realizing about social determinants of health, and some people are indulgent in high-risk behavior or even in substance abuse, not due directly to their own kind of decisions, but governed by the situation around them. So we need to be able to recognize that and be a little more humanist. And when we can understand why our patients are making certain decisions in the way that they are making these decisions, then we are actually able to treat them better. So, and this is very internalized to ourselves as healthcare professionals. So in many cases, sometimes we tend to prejudge our patients. So these needs, taking a humanist approach actually requires us to not make moral judgments, not have these very negative feelings, including things like, this fella, no point talking to him. He's entirely useless. He's not going to follow what I'm going to tell him. There's actually no point in even being aggressive in managing this patient. So we apply our kind of biases and judgments onto these patients. So and that's not something that we should be doing. And increasingly, as my colleagues, you will realize it's not something that you're doing in your daily practice as well. So we respect and accept our patients' decisions, and we try to move them a little further along the continuum. And that's really what the humanist approach is about. So the second principle of harm reduction, which has a very relevant kind of importance in healthcare settings, is this idea of pragmatism. Right. And I talked a little bit to you about that, in the sense that nobody's perfect. Nobody can ever reach perfect health behavior. It's quite impossible. And behaviors don't happen in isolation. Like, there's all these social and community norms. I talked to you about the social determinants of health, factors which are outside individual control, which actually influence health behavior. We need, as healthcare providers, to actually focus on providing supportive approaches. So where we understand that our patients are not going to be perfect, and rather than taking a very moral tone towards them and scolding them every time, your results are not perfect. I asked you to cut down your amount of alcohol that you're taking, but you've not done that. So, we need to actually approach it in a pragmatic manner, and rather focus on the larger game, larger end outcome, which is slowly moving these people towards improving their high-risk behavior, so that we can further reduce their risk little by little. So rather than, of course, I'm being very careful in taking back this message, in that if you are able to push this individual or patient that you have towards absolute risk reduction, that is wonderful. That is the ideal outcome. But we are realizing that may not happen in many of our patients all at the same time. The third kind of principle is individualism. And increasingly we're learning this in medicine in terms of personalized medicine as well. And we're finding out that like drugs or targeted therapies, targeted behavioral interventions need to apply to individuals in a targeted manner. So everyone has a different approach that you need to use to be able to attack them in order to get that message across. And while for some people, you are able to absolutely introduce absolute total risk reduction, for many people, this is not going to work. So the idea is to be able to nudge them along on an individual manner according to their own kind of preferences and kind of behavioral constructs. in terms of autonomy, we also have to realize that we may say a lot of things, but in many chronic conditions, especially, and even in our patients who are coming to us for wellness, really, they're making their own decisions, and you only see them once. And we have very little except moral authority to actually, govern them in their decision making. So we should actually be building our case in terms of negotiation, and negotiation is always going to come from us understanding where the patient is and bringing them along together within that joint decision making for us to be able to improve their own conditions, be it weaning them off substance abuse or weaning them off any kind of high risk behavior that they are indulging in. And of course, the next step is increment, or the next principle is incrementalism, where any positive change, we must see it as a step towards better health. And it's always like we need to be able to take time into account, as well as occasional circumstances, and the idea that people will have kind of plateaus and valleys at the same time in their performance. Not everybody is going to be performing well at this kind of weaning themselves off this high risk behavior or substance abuse, be it alcohol, pills, any kind of thing. Actually, even the whole big issue in terms of food, and that's a different discussion as well. So and this idea about accountability without termination, that we'll continue working with our patients as they progress or not progress, but we need to be patient and go with them. So basically, what I've spent the past couple of minutes talking to you is about introducing to you these various aspects of harm reduction, how they've been successful in a public health context in terms of substance abuse, particularly in drugs. And now Dr. Ariana is going to talk to you about how this has been misused by the tobacco industry.
Okay, so thank you, Dr. Murali, for your informative presentation. Yeah, so because I think you really give us really an overview and background understanding about harm reduction in the public health setting or in the healthcare setting. So now let us welcome Dr. Noraryana to share her thoughts on the topic about harm reduction and the false narrative by the tobacco industry. So over to you, Dr. Noraryana.
Thank you, Ms. Wan Thung. Thank you, Dr. Murali, for the presentation. So I shall share my slide now. All right. So a very good afternoon, ladies and gentlemen, dear colleagues. First of all, I would like to thank National Cancer Society Malaysia for inviting myself and the Ministry of Health in the series of educations through Dr. T. And it's been a pleasure for us in the Ministry of Health to try to educate all our colleagues in this platform in terms of the harm reduction. So we have heard from Dr. Murali regarding the harm reduction, the concept, the strategy, and so on. So basically what we can understand is harm reduction is when you try to avoid something that causes harm to yourself. And we used to do it daily. For example, the simple things is like when you drive a car, you wear a seatbelt, you try to attend or to try to avoid get injured during if it's happened on accidents. And motorcyclists, they wear helmets. And the most simple day-to-day, you wear sunscreen just to avoid radiations of the sun. So this is something that you've been doing every day in terms of the concept of harm reduction in your day-to-day activities. But as been mentioned by Dr. Murali just now, we have been doing it more than that in terms of the medical perspective, like syringe exchange, sexual health, and so on. So in terms of harm reduction, I would like to share the principle of harm reduction on drug use that has been very successful strategies besides the needle exchange that has been explained by Dr. Murali just now. I was involved in this methadone exchange program, I think more than 15 years ago. during myself posted to the psychiatric unit in one of the hospital in Malaysia. And at that time, the good part of this harm reduction concept in methadone substitute on the drug user is actually, it is very structured. The program is very structured. The methadone will be prescribed by the healthcare providers, and they have to come to the hospitals, to the clinics to be monitored. So it is not like the harm reduction on tobacco like what we've seen here in Malaysia. So when you talk about tobacco harm reduction, somewhere in 2010, early 2012 and so on, I think one of the person in China, they have invented a new types of smoking product. They call it as electronic cigarette. And the main thing that they want to use this electronic cigarette is to reduce the harm of people use tobacco conventional cigarette. And we know that tobacco for decades, it has a lot of side effects, it has a lot of health implications. But whether this concept of using of electronic cigarette can be applied to whatever the principles of harm reduction that have been explained by Dr. Murali just now, we should be dealing it with a very proper way. When we have this tobacco harm reduction, it has been, people in a large community has been talking about it. In fact, the healthcare professionals has debate about whether it's good, whether it's actually give more harm to the users. And as a healthcare professionals, when you talk about the false narrative of tobacco harm reduction, or I may say not really false, but misuse or misleading narrative of tobacco harm reduction, we must really go on into evidence-based. And in these few slides that I'm going to explain to you, I am going to base on the WHO report on a systemic review on health effects of electronic cigarette. We have two report produced by WHO. The first one was in 2015 and the second one was in 2021. It's actually just recently, just 2 years ago. And we also have a lot of other evidence as well. But in this particular presentation, I'm referring to the pulmonary illness related to e-cigarette use in Illinois and Wisconsin. And of course, I also use the study from the local universities by University Technology Malaysia 2020, report on e-cigarette content, and also report from National Poison Center, University Science Malaysia. So there's a lot of evidence. And as a healthcare professionals, when you want to explain to your patients, when you want to explain to your clients or whatsoever, you must have evidence-based, and you must look into the various examples of harm reduction strategies that has been explained earlier by Dr. Murali. So I am going to discuss whether the tobacco harm reduction is really what we call is false narrative or misleading narrative, in terms of only three that I would like to explain or to like to discuss here. Number one is safe to use. And most of the time, people always say it's only vapor, it's only water. There is nothing inside the vapor. And the most important thing, the most common one when we talk about tobacco harm reduction, they say that this is good for quit smoking and it can replace our quit smoking services. So this is one of the second one is actually quite a big issue when people tend to say that, oh, this is for quit smoking. And the third one is whether the passive exposure to vapor can really give health effects as tobacco smoking as secondary smoker in conventional tobacco. So I just want to go one by one to explain to you why, in terms of the concept of tobacco harm reduction, these three components cannot be applied to the tobacco harm reduction. The first one is on the safety, whether it's really a vapor, whether it's really water, whether it does not contain any chemicals or not. So the slide shows you can see this is a variety of smoking product in the market right now. So the left hand side, you can see this is a conventional smoking product where they burn it, and the right side is on the latest or the newest way of using tobacco, where they heat it with the electronic device, or they extract the liquid of the tobacco and then they heat it with the electronic device. So by principles of chemical, if you can see combustible product, definitely they will produce a lot of chemicals, 4,000 chemicals and whatever. Okay, produce tar, produce carbon monoxide. And we know that tar is one of the carcinogenic chemicals that can cause cancer and so on. Yes, if you compare from the product of combustible and the non-combustible product, you may have less CO because you don't burn it, you heat it. You don't have tar because you don't burn it, you heat it. So you can't be really like compare this product with the other product. It's not like you compare apple and apple. You have to compare like apple and orange in this particular when you want to discuss about harm reduction. And when you talk about the liquid itself, the vape or the electronic cigarette, many people say that it's only nothing. It's only glycols. We use glycols in our cream, in our makeups, in our cosmetics, and so on. We also use flavor. We use flavors and all of that. And of course, some of the majority or almost, I think, more 90%, more than 90%, almost 100% products, the e-cigarette products in the market contains nicotine. So all these glycols, nicotine flavors, if you don't heat it, you mix it, it will cause reactions. So there's a lot of reactions that can give health effects. And furthermore, when all these three products, you heat it, definitely the vapor, it not only produce only water. It is wrong to say it's only water, but it's produced a lot of chemicals that can cause corrosive to your cells, and it is not good for especially to your respiratory systems. This slide shows the effects, a study from the University Technology, UTM, the one that I mentioned just now, reported in 2020. So what they did was they collect all the very popular electronic cigarette, the liquid, and they shows that in the event of the bottle, it is not heat actually, it's in the bottle. So the compound, the chemical found is more than the 3 basic compound of basic chemicals that contain in electronic cigarette. So it is false. It's actually false to say that it's only 3 chemicals inside and it's only water when you heat the liquid. And from the systemic review, it has confirmed more than papers that have been reviewed by the expert. It shows a lot of chemicals. It has metals, it has VOC, it has particulate matter, it has nicotine, of course, and it has also a TSNA. But definitely people will say, oh, this TNSA will be lesser compared to the conventional cigarette. But I always tell my client or always tell my patients that which one you want. If you have one poison with 10 chemicals and one poison with 5 chemicals, as a healthcare professional, I cannot advise you to take any type of poisons. And in the same systemic review, they also noted that in vitro studies, they found effects of cytotoxicity, oxidative stress, and inflammation. Remember, I informed you just now, I told you that all these chemicals will cause inflammation because of the corrosive effects. And of course, when you inhale it into your respiratory systems, it will damage your cilia, it will damage your lining of the lungs and so on. And the same systemic review mentioned about human experimental studies. And definitely there's a lot of short-term exposure. There's a lot of side effects, short or to mid, but definitely we need still time to see the long-term effects, especially cancer. Yeah, we cannot confirm cancer right now, but through our experience with tobacco use, it takes decades for you to find whether it causes cancer or not. And to share with you, this is the health effects reported in Malaysia. And as I mentioned just now, because of the corrosive effects, it caused irritations to the lung and a new disease known as EVALI, electronic vape-associated lung injury, that has been reported many cases in the United States. And again, in the United States, when they reported EVALI, it was related to THC and some sort like vitamin E acetate. But it is different happening in Malaysia. In Malaysia, we have the first cases, actually we have somewhere in 2019, just before the COVID outbreak. And then we have another case in 2019. So 2 cases of EVALI, and it happens among the youth, among one of the secondary school students, and one more among one of the university students. So it was confirmed EVALI, and that there was no THC and there was no vitamin E acetate. It shows that the content, the chemical content in the electronic cigarette really causing corrosive effects and cause inflammations. And in 2021, we conducted special program with PPUM, that time during the COVID-19. So we have confirmed 8 cases of EVALI and 20 cases e-cigarette related use. For example, it's precipitated the infections of TB. With e-cigarette, it's precipitated the exacerbations of asthma. So you can see that all these chemicals, it's false to say that it's only water, because it caused all these cases and it has been reported to the Ministry of Health. And since 2022, I think somewhere in October last year, we started to circulate a circular asking all the healthcare providers, including private providers, to notify to the Ministry of Health on the cases of health related to our disease control divisions. And up to now, we have received already 11 cases of confirmed EVALI and 2 cases of seizure involving 2 school children. So you can see the effects of this, the false narrative on the harm reduction, which is like this is something good, this is only water, is not true at all, because by evidence it shows a lot of chemicals, and by health effects, I can show you here from my slide here, we have started to receive more and more cases. The second thing about whether it's good for quit smoking. So this is another issue that we've been dealing with. People say that now I have quit smoking, Dr. Ariana. I've quit smoking, but when I ask them, are you still vaping? Yes, they are still vaping. And study has shown that almost 80% do not quit smoking when they switch to e-cigarette, but instead they continue with that. But some of the patients, actually they are dual user. And the bad thing is, they are not even smoker before. They are free, they are like clean. They don't smoke, but they start to vape. So this slide shows that between nicotine, heroin, cocaine, alcohol, and so on, nicotine has a very high dependency, meaning that if you want to stop smoking or vaping or want to stop nicotine addiction, it's like you have to be a very good motivation, and you must make sure that you take a very structured program so that you can quit from nicotine addiction. This slide shows the nicotine receptor. So when you inhale the nicotine, whether you burn it through combustible or whether you heat it, so nicotine will goes into your lungs, and it goes to your blood circulation, and it goes to the alpha-4 beta-2, and it will produce what we call as neurotransmitters for you to get all the pleasures by vaping and smoking. And this slide shows different way of the uptake of nicotine. You can see from this one, smoking costs 10 seconds, okay, for the nicotine to go to your brain and give you pleasures. While the other type of nicotine preparation like gum, patch, it takes a slow one, okay. In helping people to quit nicotine addiction, you must really make sure that the receptor, the one that I show here, the receptor must be killed with a very slowly. You cannot replace it one to another. When you take electronic cigarette or vaping mimic the way of you smoke. Okay, after 10 seconds, the nicotine will goes into the receptor and you will get the pleasure. So while changing from tobacco to vaping, there is no chance for the nicotinic receptor to die because they are still feeling of nicotine, and you are continuously getting the pleasure. So that's why majority of the clients or the patients, they don't stop smoking. Even sometimes they are even they fall into dual users and they still continue to vaping. So this is why up to now we are still waiting. If they still that they keep on claiming, say that this is good for quit smoking. So we are still waiting. Up to now, clinical trials does not shows that the vaping can use for quit smoking like the other preparation like gum, patch, and so on. And the last one is on the exposure to vapor. Okay, while you vaping, people will say, oh, you smell good now. You smell like lime, you smell like strawberry, you know. If you smoking that you like, so you feel, you smell very bad. And people tend to forget that the passive exposure also cause a lot of problem. So based on the systemic review in the human experiments, they noted that there is a short-term lung obstruction when people were exposed to the vapor, and the non-smoker exposed to vapor have a lot of absorb of nicotine as same as tobacco smoke. So it shows that it gives effects to whoever inhale the vapor when you stay with people who vaping. And the other part of the study in the systemic review, they also do the indoor air particles and emissions, and it shows the increase in amount of nicotine in all surfaces, meaning that it affects to the passive smoker as well. And the concentration, the particles is actually counted as PM 2.5, which has very small enough to go to your lung, to your alveolar, and can cause damage to your lung systems and so on. That's why it's highly related to the cases that we're getting more and more now, Ivali. And definitely, as I mentioned, it's not merely water, it's not only the flavor that has been added in the liquid. It's actually produced benzene, toluene, and a lot of chemicals which cause corrosive and all that. So at the end of the day, while you're talking about harm reduction, we are still waiting for evidence, as I mentioned. But as time goes on, since 2015, the electronic cigarette came into the market of Malaysia, we have been working together with the WHO, with the international collaboration together with Singapore, Netherlands, and Japan. And we noted that the effects of health for electronic cigarette getting more and more. And as I mentioned just now, we are still waiting if there is a clinical trials whether this electronic cigarette is good for quit smoking. We still wait until right now. So I think with that, I would like to thank for your attention, and I'm happy to receive any questions and to answer any questions from the floor. Over to you, Ms. Wan Thung. Thank you so much.
Okay, thank you very much, Dr. Noraryana. Yeah, so I think I believe everyone would agree with me that it is a really fantastic presentation so far, and then is that all the information shared is backed by evidence. Yeah, so now we'll move on to the Q&A session. Yeah, so okay, so now for what I can see right now, so there's one question that the participant would like to ask is, so far, are there any examples of like harm reduction intervention that have been implemented in Malaysia? Yeah, so perhaps either maybe Dr. Murali and Dr. Noraryana can give your thoughts regarding this question. Yeah.
Sure. So two big programs that we do in Malaysia, and as Dr. Aryan was telling just now, one of the big harm reduction programs that's being done is methadone substitution therapy or methadone replacement therapy, which is being done now in more and more clinics, both in the public sector and private sector all across Malaysia. So that's a big example of harm reduction programs that they're doing. And of course, this needle exchange program, syringe exchange program that we continue to roll out in different communities all across Malaysia, especially among injecting drug users.
Okay, sure. Okay, thank you, Dr. Murali. So now another question is what is the role of healthcare professional in the effort of harm reduction in tobacco control? Perhaps that maybe Dr. Ariana or Dr. Murali can answer this question.
Yeah, maybe Dr. Ariana want to take this question and then I can chip in.
What is the role of, can you repeat the question?
Yeah, so what is the role of like a medical or healthcare professional in the effort of harm reduction in tobacco control? Contribute to the effort.
Yes. Yeah, as I did mention to you in my presentation just now, the basic concept of the harm reduction, the policy at the moment for Malaysia in Ministry of Health, it should be a structured program. It should be a structured program. It should be prescribed items. It should be monitored closely by the medical personnel. Harm reduction in tobacco, if you can see from now in the markets, they just you can just buy at retail and so on, and it's not properly monitored. They just claim that they have stopped smoking and all that. This is not a policy of the harm reduction as the methadone harm reduction concept that we have applied. So as a role of a medical person or physicians, I really hope that you can understand the situation to apply the harm reduction and to wait for evidence, more and evidence coming to make sure that the harm reduction for tobacco at the moment using this device or this electronic cigarette cannot be used, but definitely harm reduction or quit smoking, I can say quit smoking using other type of nicotine replacement therapy should be emphasized.
Okay, sure. Okay, thank you, Dr. Noraryana. Dr. Murali, anything that you would like to chip in or pop up? Yeah.
For sure. And I think what we realize from harm reduction is across the world that it's not about letting the patient or the person basically go on harm reduction, whatever mechanism it is, unsupervised. It doesn't work. You need very close supervision, and with supervision, the patients or the person who's using this substance abuse in this context, it's nicotine lah. So it's nicotine use and nicotine abuse. The issue will be unsupervised. They are unable to actually go on any form of significant control in terms of reduction. So, and that's really the big concern. currently, as Dr. Ariana says, the idea of harm reduction in terms of tobacco is, look, you can go to 7-Eleven, you feel like having curry puff, or you feel like having a burger, same concept, you can just go and buy any kind of product that they're labeling as control or harm reduction. One, as Dr. Ariana said, I don't think there's, in order for that to be harm reduction, from a higher level of harm, you should be coming to a lower level of harm. And we're actually seeing in terms of e-cigarettes and vape, that's actually not true at all. If anything, some people, some of the scientists and professionals arguing is equal harm. So it's harm to harm, not even harm reduction. It's a concept called harm substitution. I like to call it whether you die from car accident or you die from falling down the mountain. Same, end result still the same. So it's a harm substitution issue rather than harm reduction. First problem. The second big problem is some scientists actually argue that's harm augmentation, which means rather than you are only now exposed to conventional tobacco and cigarettes, as dual users, it's actually harm augmentation. You actually now have the risk from using conventional tobacco and nicotine from conventional cigarettes, and then you're also using vape, so you got the additional dangers from using e-cigarettes, as well as the increased dosing from nicotine and the dangers from that. So harm augmentation become another problem. And as medical professionals, we know that even for something like a disease, any chronic disease like diabetes or hypertension, we actually need to regularly monitor these patients. So if there's a role for medical professionals, yes, sure, for scientifically beneficial, okay, products used onto a population that's already indulging in harmful substances, we have a role, very strong role to play in reducing that harm. So if you call it harm reduction, yes, by using scientifically proven mechanisms such as nicotine replacement therapy and all that, that genuinely reduces their harm. And our problem is that, one, people who have, as Dr. Ariana mentioned, people who have never used these products in their life, so they actually have zero harm. Now suddenly, as users, they are exposed to a lot of harm. So it's actually harm augmentation. First problem. The second problem is for people who are already using these products, this idea of e-cigarettes and vaping is actually nowhere as safe as they are being, touted to be. And more importantly, unsupervised use is not ever in any scientific literature showing to any kind of reduction in any significant manner. So that's our big contention with this.
Okay, sure. Okay, thank you, Dr. Murali. Yeah, so I think now as we are running out of time, and just that here we have one last, I think it's not questions, it's just a statement from our doctors. Yeah, statement from Dr. Ramanathan. So he mentioned that if MOH policy is prevention is better than cure, why is it like smoking is allowed, e-cigarette or vaping is allowed and causing damage to health? And also another doctor also advocate for the Dr. Kamaruzaman also advocate like to the ban of the usage of cigarette and electronic cigarette. Yeah. So what's your any comments regarding this regarding these statements, Dr. Murali, Dr. Noraryana?
All right. Thank you so much, Dr. Ramanathan and Dr. Kamaruzaman. Yeah, I think Dr. Ramanathan and Dr. Kamaruzaman is actually referring to the current situations that's happening. Of course, this is the policy or the decisions by the government. But of course, as a healthcare provider or healthcare professionals making policies and all that, we continue to advocate our healthcare providers or our users on the effects of smoking and vaping. So this is my comment to their comments. Yeah, thank you.
Okay, thank you, Doctor. Dr. Murali, any other things?
Oh, I agree with what Dr. Arena is saying, and basically, I think Dr. Kamal Zaman says, which is the priority of life, good health, the good of money. But I think we come back to these principles of harm reduction that I was telling you earlier. Ultimately, it's in the individual's hands as well. So sure, the government can support. As medical professionals, we are ready and willing to get more and more people, one, to not start, and for those who have started, to get them to quit. That's where we come into the picture, and we continue to promise that we'll do our best at doing this for our people.
Okay, sure. Yeah. Okay, thank you so much. Yeah, I think so. That brings us to the end of our webinar for today. So once again, thank you to our speakers for sharing their expertise with us on today's topic. So thank you, Dr. Murali, and thank you, Dr. Noraryana. So we hope that this webinar has provided you with valuable insights on the, we say, false or misleading narrative of harm reduction in tobacco control. And so we just want to let you know that don't forget to tune in for our next webinar, Harm Reduction and Harms it causes from the perspective of tobacco control, which will take place on this coming Wednesday, 19th of April, from 2 to 3 p.m. On the Docuity platform as well. So thank you for joining us today, and we hope to see you again. Thank you, everyone.